would like to thank the provider for this great organization, for great conference, and for inviting me to be with you. I am the one to be honored that you accepted my YouTube Academy to stream the lectures. Thank you very much. And now I'm going to talk about how much do we trust business. It's a very good question because we in the market we can see that there are a lot of machines nowadays, and we wonder which machine is the best to buy. And I'm exposed to such questions every day, almost every day. Which machine to sell, to buy? Now, actually, to be not guilty when you have a problem after the operation, then you have to know which machine you have to depend on and what knowledge you must have before you proceed with your practice. I have no financial interest, of course, and I'm not going to concentrate on one machine, but I'm going to talk about systems in general. Starting with a proper machine. When I say proper machine, it does not mean that you have to buy this machine. It means that in your clinic, when you have specific problem in the cornea, you have to know which machine to order a picture from. So, for example, if you have something on the corneal surface, you have to be oriented towards Placido-based. And if you have something within the thickness of the cornea, posterior surface, then you have to go for shine flood-based or scanning slit-based or the new technology, which is the high definition OCT-based. The ideal tomographer should make direct measurements rather than calculations. I'll show you later what this means. Can describe the anterior surface in corneal opacities, is sensitive to misalignment and bad captures, can measure angle kappa or lambda directly, not indirectly, has an infrared pupillometry, and has a specific keratoconus indicator, just to give you a warning sign. Starting with the direct measurement rather than calculation, we know that topography is Placido-based because it describes the anterior corner surface, while tomography is shine flood-based or slit scanning based or lid-based. Now in Placido, vice versa can be said for the shine flood-based imaging systems. So the shine flood-based, they measure directly the elevation maps, but they calculate the curvature map. So there is no direct measurement of the curvature map. So the best is to have a machine which is a hybrid, which combines Placido with shine flood or Placido with slit scanning, because there will be direct measurements to both curvatures and elevations. The ideal tomographer can describe the anterior surface in corneal opacities. Scanning based, it depends on a slit light which goes through the thickness of the cornea, and it will suffer from scattering when it passes through the scars. And this scattering will give false measurements and false calculations. Why? If the patient has a surface scar in the cornea, or even a scar in the stroma, and you want to study the anterior surface properly, you have to depend on machines that include Placido in the system, because it is the best to describe the anterior corneal surface. This is why, if you want to go for topography guided treatment, it is best to use a Placido-based system to describe the anterior surface rather than the shine flow. And if the machine has both, it will be much better. The ideal tomographer should be sensitive to misalignment and bad captures. This is a case of misalignment taken by a shine flow-based imaging system. As you see, this shine flow-based imaging system shows that the quality specification is okay, meaning that this capture is okay, while the patient was looking downward during taking the capture, and this system missed this problem. So based on this, you may put a diagnosis of keratoconus, and you may act based on that. So you may go for cross-linking while the patient was just looking downward and he has no keratoconus. Look at the red arrows. They point at missing data, empty spikes. And if you choose another one, you will find that the data are there, so you can click on it in order to study it. Furthermore, there is a system of 85% to accept it, and for the other two parameters, they should be more than 95% to be accepted. So as you see, more parameters in Placido, in hybrid or Placido-based imaging systems. Number 4, the ideal tomographer should measure angle kappa or lambda directly, because they are very close to each other. Like in this one, lambda intersect the x-coordinate of the angle and the y-coordinate, while the purely shine flow-based imaging systems that do not include Placido inside, they do not measure angle kappa. They may measure it as chord mu, which is the relationship between pupil center and corneal apex, which is wrong. Shine flow imaging systems in taking the capture for pupil diameter. And we don't use the ruler, which is a very rough way. We have to have an infrared pupillometry, which is implemented in some systems like this one. Has a specific keratoconus indicator like this one. This is, let me start with this one. This is a case of normal cornea, but after treatment. This system depends on um, 5 maps, which are the tangential anterior, tangential posterior, the elevation versus normality. It compares the elevation map of the patient with the normative data of normal population for the anterior and posterior corneal surfaces, in addition to relative pigmentometry map, which is as well comparison of the thickness map of the patient with the normative data. So there are normative data according to which the data of the patient are compared, and based on that, the machine can tell you that this is a normal cornea or an abnormal cornea. This is another example, an abnormal cornea, and if you look at the picture, which is lower right, which is at the bottom right, you will find a red circle. This red circle, if it is very small, it means that the highest peaks in all maps are very, very nearby each other's, which is found in ectatic corneal diseases. So this is why it's very small. While in normal cornea, it is very wide. Look at this one. Very large red circle, meaning that this cornea has no ectasia. On the other hand, the shine flow keratoconus screening systems like Belen Ambrosio displayed in the pentacam will miss many things because it is based on elevations, not on curvature as well. So this is a case where BAD is very normal, while the patient has a keratoconus suspect. Look at the upper left map, which is a very abnormal anterior curvature map, and in spite of this, the Belen Ambrosio display just show it is normal. So, in order not to be guilty, you have to know which machine to capture the patient, the eye of the patient. In addition, you have to have the basic knowledge for interpretation. But there are facts that we have to highlight, like ectasia and other complications may happen even in very normal corneas. And there is no agreement yet for the definition of abnormal cornea. There is no agreement for the definition of thin cornea. There is no agreement for the safe threshold of the percent tissue altered PTA or the residual stromal bed. Some people depend on this, some people depend on that. And there is no 100% sensitive and 100% specific matrix to check or to find out any abnormality. Either you will find very high sensitive and lower specificity, which will give false positives, or lower sensitivity and higher specificity, which will give false negatives. If we depend on single parameters, like if we say A max, thinnest location, highest point on the elevation maps, these are points, and these points are prone to artifacts. And you have to have the knowledge how to find out the artifact. Based on that, you can say that this capture is acceptable to me so that I can make a decision based on that, or you will say no, it is not acceptable, and you will send back the patient to redo it. Ocular surface disease affect to a large extent because of dryness, because of arteriopathy, the K readings, the thickness measurements, and so on, in addition to technician mistakes and patient's mistakes during taking the capture. So, as I said, there is no agreement for the definition of abnormal cornea. So if you see this cornea, some people may say this is normal cornea. Some people may say this is abnormal cornea. And unfortunately, some doctors are diagnosing such corneas as keratoconus and may go for cross-linking to the patient just because they saw some irregularity on the anterior corneal surface, while other maps are very normal. Sometimes we find both eyes with the same problem. So is it enantiomorphism, which is a mirror shape, or is it a keratoconus suspect? So you have to have such basic knowledge before proceeding with LASIK to this patient, or assuming that LASIK extra or PRK extra is a solution for such patients. When you have a thin cornea, just thin. The curvature map is okay, the elevation map is okay, and just a thin cornea. Is it normal or abnormal? You have to have the basic knowledge for that. Do you do PRK for this patient? Do you do LASIK for this patient? This is a big question. Sometimes you may find some people may do correction of -2 sphere on a cornea which is 440 microns, assuming that after the operation the cornea will be more than 400 and everything will be fine. You know the PTA, which is the ratio of flap thickness with ablation depth divided by central corneal thickness altogether multiplied by 100, and the cutoff value is 40%. Now, it is much safer to depend on this rather than depending on the residual stromal bed to be 250, because previously we knew that the residual stromal bed should be at least 250 or sometimes 270. But if we have a cornea of 600 thickness and we follow the residual stromal bed of 270, it means that I can ablate 200 microns, for example. If I want to use a flap of 130, for example, am I allowed to ablate 200 microns? So as you see, depending on the PTA, although it is very sensitive, which means that we will exclude patients who are good for LASIK if we depend on the PTA, I think it's better than including patients who are not suitable by depending on the residual stromal bed. So you have to have such knowledge. In addition, don't depend solely on the diagnosis that the machine will give you. Some machines will give you this is keratoconus compatible, keratoconus suspect. Don't depend. Just make it as a warning sign, and then you have to look for other parameters to be sure that you study the patient properly, because there is no 100 sensitive, 100 specific vertex in the market. As I said, single parameters are prone to artifacts because of usage of contact lenses, dry eye, opacities in the cornea, opacities in the lens, and whatever. This is an example of such criteria. If you go to the literature, you will find progression criteria in many studies are different. In addition, they include different values for the same parameters. Some studies will consider progression if there is a change in the Kmax more than 1 diopter. Some consider it as 0.75 as a cutoff value. Some consider thickness. Some consider visual acuity. So there is no general agreement about such parameters, and they are prone to artifacts. Ocular surface disease, this is an example. This is a dry eye before treatment of dry eye, and this is after treatment of dry eye, and you can figure out how much the cornea became more regular. This is of excess tears on the left side before giving the patient a tissue, and this is the same session after giving the patient a tissue to wipe his tears. Technician mistakes and patient mistakes. These are the factors of false positives and false negatives. You have to be aware of these factors, like contact lens usage. Many patients may come and take off their contact lenses in your clinic, and they are coming for the refractive surgery. Misalignment during taking the capture, large angle kappa and its effect, tear film disturbance, posterior surface astigmatism, which has an effect on toric IOL calculation, corneal opacities and pathologies, previous corneal surgeries. Many patients may deny that they had previous corneal surgeries, early cataract, bad exposure to the camera, and pregnancy. During pregnancy, we all know that there is an increase in thickness and an increase in K readings. The cornea becomes thicker and becomes steeper, which will cause false readings. So this is why we have to ask for pregnancy if we are planning for any measurement of the cornea or even refractive surgery. So nobody will forgive you if you are going to do corneal refractive surgery in inter-eye asymmetric tomography, like when you have one eye normal and the other eye has an abnormality. So if the patient has in the future ectasia, nobody will forgive you for this. And if you are going to do refractive surgery in eyes with warning signs, there are a lot of warning signs, like these signs. You have to be aware of all of these signs to be sure that you are studying very well and interpreting the corneal tomography very well. Nobody will forgive you if you induce abnormal corneal shape after the operation, like oblate, hyperprolate, or small efficient optical zone or decentered zone, such as in this case. Look at this case. Can you imagine that this patient has, after operation, 27 central, 27 diopter of K readings? What do you think that this patient is suffering from? Spherical aberration to very high extent. Now, this is a steep optical zone. This is a small optical zone. This is a decentered zone. So, as you see, you have to be careful not to induce such problems by studying very well the tomography. Nobody will forgive you if you implant premium lenses, like multifocal lenses, in corneas with RMS of high order aberrations more than 0.5 diopters, because the patient will be suffering from high order aberrations. In other words, if the cornea is irregular, you cannot implant multifocal lenses. Like in this case, for example, this patient has a comma of 0.67, which is very high, and he has, this is another example, trefoil 1.2, which is very, very high, comma is 0.72, and spherical aberration is 0.65. So this cornea is very irregular. So you cannot say that, okay, this patient can go for multifocal lenses. And especially when the mesopic pupil is larger than 6 millimeter, then multifocal lenses or even trifocal lenses will have the effect of halos or glare. So in conclusion, it's better to depend on a technology that is based on more than one system, like a combination of Placido with high definition OCT or Placido with shine flow imaging system. And you especially that this ideal machine should do direct measurement rather than calculation, can describe the anterior surface in corneal opacities, is sensitive to misalignment and bad captures, can measure angle kappa and lambda, directly has an infrared pupillometry, has a specific keratoconus indicator. You have to follow a systematic subjective evaluation. Make your own subjective evaluation, not to miss any point during studying the patient, to avoid any complication during and after the operation. Pay attention to inter-eye asymmetric tomography. Pay attention to warning signs on tomography. Pay attention to corneal shape and sufficient optical zone. Sufficient optical zone is very important to avoid small optical zones after the operation. For example, if the patient has -6 sphere and you are going to treat him with an optical zone of 6 millimeter, you will be surprised that after 3 months, if you do a tomography to him, that his optical zone after the operation is only 5.25, because the higher the correction, the smaller the optical zone that will be after the operation. So it is always recommended to follow guidelines and not to reduce the optical zone to gain more tissue and to gain more correction. You have to study corneal wave front properly before making a decision, even if you are going for -1 treatment for PRK. You have to. And you have to measure the pupil professionally by using an infrared pupillometer rather than using the ruler or depending on the shine flow-based tomographers. Thank you very much.
visit the ophthalmology service in the military hospital here in Muscat. And it's a very nice facility with many machines. And they had very interesting discussion with Dr. Rashid. And I told him it's better to rely on anterior topography and OCT rather than beta-cam. And I'm glad that Dr. Sinjab agree with me. So I'll just continue on the same path and tell you more about, high definition OCT and the future of that in corneal refractive surgery. So HD corneal OCT has benefited from many advances, and the most important of them is a higher scanning rate and using shorter wavelength. And this way you can achieve a very high resolution, but one of the drawbacks is that you have small depth and a smaller field. And you see here comparing the two images of the Zeiss machine. The upper one is from the Byzantine, so you can see the whole arterial chamber. And the new machine, the Cirrus, you see here, you don't see the whole arterial chamber, but you have much more higher resolution for the cornea. Just to give you an example, this is a case of pellucid marginal degeneration. And you see here, using the Byzantine machine, this is the pachymetry map. And you see here, you can see the peripheral inferior thinning, but you see that there is some details are missing in the left eye. And just to compare, this is the OptiView machine, reactive hyperplasia of the epithelium. And this is a new element that would help us to better diagnose keratoconus and to better understand the physiopathology of this ectatic disease. Also, Dr. Mazen mentioned that it's a problem on a regular cornea. This is the topography of advanced keratoconus with endothelial scar, and you see the anterior topography is not very good quality. But look here at the OCT, how regular it is, how very precise information you have. So on the left side you have the whole pachymetry map, and then on the right side you have the epithelium map. And you see here the very characteristic image which has been described. It's the image of donut. So you have in the center thinning of the epithelium, and you have all around reactive epithelium hyperplasia. This is the natural mechanism of the cornea to smoothen and to decrease the regularity of the cornea. But I think the big advances in HD corneosity is also called segmented cornea maps, which means that you will have a map of the epithelium, of the Bowman layer, and of the stroma. And you see here a comparison of a normal map, which is to the left, and the keratoconus map to the right. And you see, we can see a sign of keratoconus on the three levels of the cornea, consisting of thinning of the epithelium, thinning of the Bowman layer, and also thinning of the stroma. And this is novel information that you can use to better diagnose this kind of disease. How about corneal tomography? I'm just going to repeat what Dr. Mazen said. They basically suffer from, intrinsic weaknesses. And the most important of them is low spatial resolution. And that's why the majority of this machine has to be combined with the placebo disc, because they don't have enough resolution especially for corneal curvature. Even the Pentacam, which used to be a standalone machine, now is proposed combined with another machine, the Corvus, which the combination of both elevation map and biomechanical map will help you better diagnose, especially early form of keratoconus. And you see here, this is a very recent paper by many authors. I'm just here assisting that Dr. Obiozo is part of them. And you see here to detect subclinical keratoconus, if you just use the Pentacam, your accuracy will be less than 70%. And you have to combine with biomechanical data to have a higher accuracy up to 80%, but still not the 100%, which the ideal we are all looking for. It also has been suggested to combine the Pentacam with high repetition ultrasound to better diagnose the early form of keratoconus. Also, like it has been mentioned, it's an optical system, so it's very sensitive to interface and clarity artifact. This is just an example. We know all the typical image that we see after LASIK with the orb scan. You see this big red dot in the center suggesting that you're having some kind of ectasia. This is just an artifact because you are modifying the anterior surface of the cornea, so automatically you have this artifact on the posterior part of the cornea. On the Pentacam, show about the same thing, but to a lesser extent. So Pentacam is better for the posterior surface than the orb scan. And this is just the same patient on HD OCT. You see how regular is the uncentered photoablation on the pachymetry map, and below you see the typical aspect of epithelium following myopic LASIK. So you have thinning in the center, more thinning in the mid-periphery, and more you have thickening in the center and more thickening in the mid-periphery, and then you have thinning again in the extreme periphery. And this is the same patient after 1 year showing total stability. So actually it was not the case of post-LASIK ectasia, just normal outcome. And this is on topography. Topography is still the reference system for corneal and refractive surgery, and showing also here stability at 1 year. The other problem, if the cornea is not very transparent, like the case after cross-linking, this is a patient 1 year after cross-linking, and you see when you measure the thinnest mold using the Pentacam, it's 400 micron. But when we compare to HD OCT using the OptiView and the Cirrus, you see the difference is up to 35 micron between the two machines. And actually it's the same patient. And the reason for that, because the cornea after cross-linking is now so transparent. And that's why the data coming from the Pentacam is not correct. So the main problem is lower accuracy and lower reproducibility, especially in abnormal cornea like in keratoconus. And the reason for that, like Dr. Mazen mentioned, you see the Schönflug image is very sensitive to corneal opacity. It's not the case for HD OCT, which is the lower image. And this is a nice study that have been showing that the pachymetry you measure with OCT is lower than the one measured with the Pentacam, both in normal and keratoconus, and you can have variation up to 117 micron, which is a lot, and up to 17 diopters for keratometry. And this is just showing the same thing, the difference between Schönflug and OCT image. And you see here comparison between normal and keratoconus population. You see a normal population, there is somehow a good correlation between OCT and pentacam. But look in keratoconus population to the right. You see how much scattering is there. There is almost no correlation. This means that tomography is not working in abnormal cornea. And how about the metrics like curvature, thickness, and elevation? Actually, the pentacam will give you steeper keratometry and thinner pachymetry. And when they do the comparison, the most important that the reproducibility is much more better with the HD OCT. This is just showing you an example of keratoconus, just showing that with the HD OCT we have lower value. Generally it's about 15 to 20 micron. And you see here we have much more information on the HD OCT map, both for the stroma. You see you have much more higher resolution, and also for the epithelium, and you see the typical aspect of central thinning and then all around reactive thickening of the epithelium. It's very important, as has been mentioned previously, that we have a very sensitive criteria to follow keratoconus, to make the decision to cross-link or not to cross-link. And there is several papers showing that probably the most sensitive parameter is the corneal thickness. And this is a nice study showing that with HD OCT, you can, the cutoff value to detect progression is as low as 5 micron of thinning of the corneal thickness. But if you use tomography, it should be above 1 diopter, so it's much more or less sensitive to detect progression. And this is just to give you one example. This is anterior topography. You have to the left side before, and which was no, excuse me. To the left side, it's 8 years after cross-linking, and to the right side, it's 9 years after cross-linking. And when you compare the two maps, look at the steepest scale, K-max. It's about 45 diopters at 8 years, and here it's 48 diopters at 9 years. So based on that, it looks like it's a progression, but actually it's not a progression. Actually the patient is improving. You see here the differential map between the two. There is actually flattening in the center, in the periphery, and steepening in the center. Actually what's happening, because of the effect of the cross-linking, the peripheral thinning is moving to the center. And, so the cornea will become closer to more physiological profile. And you can see this is better on HD OCT. You have on the left side 8 years, and to the right side 9 years. And you see the thinnest part of the cornea, which used to be in the periphery, is moving to the center. And you see the area of epithelium thinning is actually decreasing and moving to the center. And this is really will reassure you that this case doesn't need cross-linking. Actually, it still continue to improve. And just to give you more confidence, this is showing the demarcation lines at 8 and 9 years. And finally, it's extrapolated matrix, so it's adherent data. And you see here the comparison of the 3 different tomographers. And the difference came up to 12 micron. This is very huge difference. And for anterior chamber depth is up to 0.3 millimeter. You know, 0.3 millimeter can make you decide to do or not to do phakic highway. And also another point that probably maybe Dr. Rashid will discuss later, if you do customized cross-linking, Normally you should do it in the thinnest part of the cornea, but look here, on the pentacam showing one location, and the HD OCT is showing another location. And the posterior float is showing the third location. So which one to trust? And from I know now, for example, Dr. Theo Sela is exclusively using the HD OCT to center his customized cross-linking. Because this is direct metrics, it's not extrapolation. And finally, the problem of post-LASIK biometry, if you need to do cataract surgery, it has been shown that true keratometry measured by HD OCT is much more better than the one measured by tomography. The same thing after corneal transplant, and also after refractive surgery. When you do differential topography, generally it's different from the achieved correction, and we don't understand why. But if you do the measure the corneal power before and after with HD OCT, it's exactly the refractive change, so it's much more accurate. And the last thing I'll talk about is keratoconus. This is a case of advanced keratoconus, and you see typical sign of the epithelium of central thinning and reactive all-around thickening. And using HD OCT now we have much more information and will tell us much more about the physiopathology of keratoconus. You know, there is a lot of debate if keratoconus starts in the posterior part or the anterior part, but based on these images, it's actually stopped in the epithelium and exactly the bowman layer. You see, when you compare normal and subclinical keratoconus, the thinnest point of the stroma is central in normal. Keratoconus is inferior temporal. Thinnest epithelium is superior in normal cornea, but it's inferior temporal in the keratoconus, and you have reactive thickening in the opposite meridian. And you see here the nice study comparing you know, the epithelium map with the pachymetry map, and showing that the epithelium map is much more sensitive to detect keratoconus than the whole pachymetry map. And the last problem I'll discuss is the one of frost keratoconus. You can see this patient, one case of advanced keratoconus, the other eye absolutely normal on anterior topography, showing a percentage of 81% normal. So maybe in using this HD OCT, and you see here decentration of the thinnest epithelium point. This is may give you information to detect this kind of keratoconus, because with the technique of tomography, and this is a nice paper comparing all machines. There is non-discriminating criteria, and all the machines are about the same. And the recommendation they made is to lower the cutoff value. If you lower cutoff value, your sensitivity will be, your specificity will be too low, which means that you have too many false negatives. I mean, you will exclude more than 20 or 30% of normal patients from surgery. So the future is HD OCT. You see here the fun frost keratoconus, and you see the typical epithelium thinning. Useful at all. And the last advance in OCT, it's also measuring the thickness of the bowman layer, and also showing that the thickness of the bowman layer is also a good parameter to detect keratoconus. And you see here, there is a new index, it's called Bowman roughness index increase, which probably the first thing that happen in keratoconus is these small breaks in bone layer. And look here, when you compare axial curvature using pentacam and OCT epithelium, and up to the extreme right, this is the OCT map of the Bowman level. And you see you have much more information on the detection of keratoconus. And this is just the future. You see much more higher resolution. You see typical case of keratoconus, epithelium thinning on one side, epithelium thickening on the other side. And also the model machine will be able to do also the biomechanical investigation. But here we have to talk about high definition. You see, these are two topography. The one to the right is low definition. The one to the left is high definition. So this is the machine you should use. As to the tomography, I think now we are in turning point, whether it has to evolve or to disappear. And OCT is the present and probably the future. And especially, I think we'll be more and more talking about Bowman layer topography and the evaluation before and after refractive surgery. And thank you very much.
All these problems in Oman, and then I think the problem always is low myopia. So low myopia till now, no actual solution for it. Those people around -1 or -0.75. There's some people they are looking for the perfect vision. Although we advise them sometimes to keep it because like threshold, -1 threshold for us for the future. We don't need reading glasses when we are old. But some people still insisting they want to go to 0 or neutral. So there's always something. But the normal refractive surgery is sometimes difficult for this group of people. So I think at Pedro they try to find some way which I hope, and I think there's some vision that will have good future. And in our center was selected to do 5 patients using no surgery, actually. Only like, we can say like medical. We don't say for them surgery, we say medical treatment. Equal. So I'll talk about it now. Customized corneal collagen cross-linking for low myopia is a novel application of cross-linking. The main indication for cross-linking is the management of keratoconus and corneal ectasia, usually till now. The concept of customized corneal collagen cross-linking for low myopia is derived from central corneal flattening. The purpose, this is a small study we conducted at the Ophthalmology Center, AFS, and we have to report around 3 months till now. But we are intending to follow those patients exactly equally, all the 5 patients for 1 year, to get the real result. To report the 3 to 12 months this study, but some people they did it around 20 years also. Best corrected visual acuity should be 20 by 20. Myopia around from minus 0.75 to minus 1.5 included. Cylinder max 0.75 minus. Exclusion, non-sensitivity or allergy. Keratoconus of course out. Any previous ocular surgery from current or history of any ocular pathology, nystagmus, of course, all those inherited eye diseases, pregnancy, as Professor Mazur said, it affects the quality of the cornea. Any medical condition that, in the opinion of the investigator, would increase the risk of complication, of course. So we agree. So we can see we treat usually the hair, not unlike the keratoconus, we treat mainly the center, the small center in the center, which you can see. So we are not going, it's very narrow and circle we make. You can see here, this vision after the treatment, you see the dye, or there was the dye. You can see the name. You can see the line near the indivisible.
LCD screen doesn't work.
Here, up. You don't know them. Almost here. Lower than that. You can see the line of the dye which used for the treatment. It goes deep. It's around one week after the procedure. And here you can see that like haziness happened in the center. Here, because it's LED screen, not showing, I don't know why. Go to the back you can see the haziness in the and here in the center. This post-op. And here, if you go to the next, it's pre-op, it's normal, you can see. So there is some haziness in the central part, circle of the cornea. You know, and they commented all with photographs. What they do. The method: 5 patients with corneal non-ectatic corneas underwent the customized corneal collagen cross-linking procedure for reduction of low myopia. Treatment was delivered with intact epithelium through application of riboflavin. It's 2 parts. It's different than normal cross-linking. So the method more or less same. We use same machine which used for customized cross-linking. There's 2 types of dye. Part 1 is concentration, different concentration. The first one 0.25% of riboflavin. The part 2 0.22% of riboflavin. So the first one usually will loosen the epithelium layer, and second one is mainly for penetration, followed by ultraviolet light. So only the central 4 millimeter cornea was treated. But first, part 1 used for 4 minutes only, interval of 1 minute. That means 4 times we put drops of that dye. And part 2 for 6 minutes, interval of 30 seconds between them. That means total of 12 times. And then after that, oxygen after 8 minutes. That means the last 2 minutes from part 2, we put the drops and while the ultraviolet light is on. So 8 minutes without ultraviolet, last 2 minutes with ultraviolet light. And of course the patient we put goggles, both goggles, those control that. Then we deliver more than 90% oxygen to the cornea during the EB-on cross-linking procedure. And this is also percentage of oxygen, we measure it. We have oxygen meters. So we make sure the oxygen concentration more than 90% on the eye, in the goggles. The goggles, of course, from the top are open, not closed completely. You can see the goggles, right? Only the laser here, this type. Clinical evaluation included anchor and Uncorrected distant visual acuity we take for the patient or the patient. Corneal topography, of course, corneal OCT, care readings. Assessment was scheduled as pre-op, post-op 1 month, 3 months, 6 months, 9 months, and 12 months. So this is the procedure how we done. Here you can see the mouse here for this one. You can see this is the goggles open from top, and this the oxygen comes from the side, and we make sure the oxygen concentration stay inside with humidified 90 or more. Most of the time was more than 95%. And this is the setup like this. Then the machine will be set up, and as you see, the treatment only the central part of the cornea will be treated. And with the energy time, the machine has got control everything, and the machine by itself will ring at the time of the drop every time. So there's no chance to miss any drop. The result: 5 myopic eyes, mean spherical equivalent was minus 1.2 range to 0.75 to 1.5. Of 5 subjects, the age of our 5 patients are between 23 and 33 years old, which is usually more than 23, less chance of having again more myopia or something like that. We enrolled in the study and treated from 21st of October to 12th of November 2018. At 3-month post-procedure, a mean spherical equivalent reduction of 0.75 was observed, with a corresponding gain in uncorrected visual acuity of 0.2 log. All patients had best corrected visual acuity, of course, 20 by 20 post-op, so no worsening actually for those patients, while 3 patients achieved uncorrected visual acuity of 20 by 20 after 3 months. Others 2 patients had a reduction of spherical equivalent of almost half, with visual gain of 0.1 logmar. Transient corneal haze was noted, which subsided gradually. There were no cases of ocular infection or secondary ultraviolet related change to the crystalline lens or retina during the last 3 months. The follow-up also showed some punctate epithelial erosion on day 1, and was noticed in all 5 patients. Corneal haze on day 1 very mild, notes only in the central treated area. All 5 patients have grade 1. Corneal haze on day 30 almost disappeared completely. Scattered of light on day 30 was reported by 1 patient only. That complaint absorbed by the next visit. That's been after another. Conclusion: the epithelium on customized corneal collagen cross-linking was effective in reducing myopic refractive errors in this study group. Early results of the novel application of collagen cross-linking are encouraging, but long-term data is in larger studies are required. Thank you for this.
Thank you very much, Dr. Rashid, for sharing with us this information on this novel and promising technique. I would like to call our next speaker, Dr. Salman, who will speak on surface ablation.
Organizing committee for this wonderful conference. I will be honored to be here as a Syrian speaker in this conference. My presentation today is about the resurgence of surface ablation, and I will speak about my own 8 years experience with LASIK technique. So, this is Charles Darwin. As we know, if we look at LASIK versus surface ablation, we know that LASIK has flab-related complications, increased risk of ectasia, flab-induced higher order aberration, and the risk on the posterior segment, such ischemic optical neuropathy, macular hemorrhage, early BVD, and occasionally retinal detachment. While surface ablation has its disturbing pain, slow healing, the vision-threatening haze, and regression. Looking at the outcome with regard to stability, safety, and efficacy, we know that it's been published or it's been reported in many publications that there is no significant differences between both techniques. While surface ablation has increased haze and regression, but also it has better result with customized ablation, less induced hair order aberration, less risk of ectasia, and less dryness. We have different types of surface ablation, all depend on removing the epithelium and ablating the stromal surface. We have PRK, EpiLASIK, LASIK, and the most fashionable surface ablation technique, trans-PRK. Trans-PRK and LASIK have some similar advantages, as both techniques preserve the epithelium as a biological contact lenses. So they have, or they reveal so in both techniques, we have less need for mitomycin C, faster visual recovery, less pain, and less hair formation. But still, trans-PRK has some superiority to other surface ablation technique, as it's all laser step, so it's touchless to the patient, which means less stress and less cyclotorsion. And also, as it's one step, so it means no gap between epithelial removal and stromal ablation, which means less stromal dehydration. But what are the disadvantages of trans-PRK? Looking at the economic issue, we know in trans-PRK we need a laser pulse to ablate the stroma and a laser pulse to remove the epithelium, which means more laser pulse needed. And this means shorter laser head lifetime in PRK. And also, regarding the accuracy, trans-PRK has the assumption that the epithelium thickness is 55 microns in the center and 65 microns in the periphery. So in cases of thicker epithelium, so the laser beam, which aims to ablate the stroma, will ablate the epithelium. So we might be ended with undercorrection and sometimes with no correction at all. So it's not recommended in cases of low myopia, less than 1 diopter, or low hyperopia, less than 1.5 diopters. Since 2011, I've done more than 1,500 patients using surface ablation or LASIK technique. And I can say during the last 2 years, about 70% of my practice was LASIK surgery, surface ablation. So I'll try to present some tips for optimum LASIK result. The correction I've been using, or I've done, for myopia between -0.5 and -7 diopters, and only 19 patients, or 19 eyes of 10 patients were between -7 and -9 diopters. For hyperopia, between a +1 and +5, and astigmatism up to +4. And I've been using wave-front guided for selective cases for those with high myopia, hyperopia, and astigmatism. So always we'll have to predict those who may develop haze and regression, such those with high myopia, hyperopia, and patients on medications such retinol, and also those with surface disorders such dry eye, rosacea, and chronic blepharitis, and also patients who have had previous corneal surgery. And I can say that only one eye of 20-year-old female who had bilateral LASIK surgery to correct long to moderate myopia developed late onset haze in one eye. Also, mitomycin C was applied. And for me, that was due to previous corneal surgery and done in the non-ablated zone. So I think that was due to previously activated keratocytes. It's the same for the patients who have had corneal surgery. And for those patients, mitomycin C was effective in all my patients, but for those who had the corneal laceration or corneal scar due to traumatic reason, mitomycin C was not effective to prevent haze. That's the message which I want to deliver. So also I have 20 eyes who have developed uncommon significant early haze, which healed completely, but I think that was also due to lack of maintenance of the laser system and or early removal of contact lenses. Technical consideration. I'm used to apply preservative-free, non-anesthetic preservative-free eye drops. So for 20 minutes, and this may help to loosen the epithelium. And I use alcohol 10% for 40 seconds, and will have to take care not to have the epithelium whitener. Also, we will have to take care to prevent alcohol escape, so that which might cause stem cell damage and increase inflammatory process and haze formation. Also, we'll have to match the DIL diameter with the intended ablation. And as you can see, it's very easy procedure. Okay, then we ablate the stroma, and then we can replace the epithelium. So, also we have to consider the causes for delayed epithelial healing, such hyperopia, tight contact lenses, dry eye, allergic to preservative in the eye drops or in contact lenses, blind stem cell damage, infectious or sterilized ulcers. Corneal haze, fortunately, corneal haze has decreased, and this is due to a better laser system, also mitomycin C usage, and the techniques which depend on preserving the epithelium as agrological contact lenses, such LASIK and Presbyopia. To avoid haze and regression, regular maintenance of the laser system is important. Treating surface disorders and blepharitis before surgery. Mitomycin C should be applied in cases of any correction of hyperopia. Why? In case of hyperopia, the haze will not be formed in the corneal center because we are not ablating the corneal center, but it's important why to prevent regression. Why regression is occur in hyperopia? Due to epithelial hyperplasia, which might induce flattening of the central cornea. So also in case of high myopia, when we have treatment depth more than 65 microns, also in case of previous corneal surgery, case of retreatment. Management of haze and regression, also I have a message to deliver here that also will have, when haze occur, we can try to prescribe prednisone 1%. If it improves, we can go on. If not, we can stop to get a sterilized refraction, and then we can go for PTK, PRK, and mitomycin C. But regarding the girl which I speak about, I did these maneuvers, but haze was regressed. So I waited, then I did LASIK. Even the haze was evident on the cornea, and this is my message, that in case when you apply mitomycin C in the first procedure, wait. If it heals, it's okay. If not, we can try to do LASIK rather than doing this maneuvers again. Overcorrection, we'll have to consider the causes, such humidity in the room, too much hydrated stroma, also cases of miscorrection, and if it happened, we can try to stop steroids and sometimes we can use contact lenses, as this might stimulate wound healing response and hyperplasia and ablation. Thank you very much.
With the surface ablation. I would like to call our next speaker, Dr. Martin Dirizama, who will speak on Relax Smile.
Yeah, hello everybody. I want to first of all thank Dr. Rashid for the kind invitation to be here and talk about Relax Smile, so the pros and cons about this new fancy technique. So, just waiting for the presentation, so here we are. So we are running a private office in Austria and we are doing approximately 80 to 90% Relax Smile so far. So, after all, we have to be careful to really look at this new procedure in detail and talk about the pros and cons. So, as you maybe know,
erzeugt der Femtosekunden-Laser, wie Max von Carl Zeiss, eine dünne Hornhautlinse, das sogenannte Lentikel, und einen weniger als 4 mm kleinen Zugang in nur einem Schritt. Das Lentikel wird anschließend durch den kleinen Zugang entnommen. Die neue Flap-Freiheit ermöglicht damit erstmals eine vollständig minimalinvasive Sehkorrektur.
I quickly go through the indications. I think you already heard about it. I just want to point out that these are the suggestions by the German Society of Refractive Surgery. And as you see here in red, hyperopia is not recommended anymore to do a keratoconus LASIK procedure. If we talk about indications, of course, Relax Smile, we know, has a disadvantage due to it's not possible to do hyperopic correction so far. The company and colleagues are working very hard on this project, but to my knowledge, it will take at least 1 or 2 years to get it approved. For myopia, it starts at -1 up to -10. There are already studies in, I think in Egypt, up to -13 diopters myopia, but it's not approved so far. So what about the exclusion criteria? They're also pretty similar to those of LASIK, which means pupillometry should be more than 480 microns pre-op. The residual stroma thickness should be at least 250, but better 280 microns. Of course, if you have massive corneal vascularization, it might be difficult also with corneal scars or very small white-to-white or speed corneas. You also have to be careful in very low myopia, which means you have a very thin lenticule, which makes it maybe very difficult to remove the lenticule. We did some study about that you could raise the minimum thickness, which means it's a neutral block on the lenticule, which makes it easier to remove it, and it's as similar good as the normal procedures. So what about the literature and what about the data about Relax Smile? This is one of the studies showing a comparison between Smile and femtosecond LASIK. Undercorrection, so we had an undercorrection of approximately a quarter diopter. What we changed is our protocol, so we do approximately 5% overcorrection in our myopic Smile patients. So here maybe femtosecond LASIK do have some advantages in terms of target refraction. What about stability? There's a nice paper published in 2016 by Professor Blum and Professor Secundo. this is the very, very first data of RELAX SMILE and the very first long-term data. So these are 5 years results, and it actually shows a pretty stable curve, which means a regression rate of approximately half a diopter after 5 years. Compared to the other techniques, we know in PRK we have the lowest regression rate of approximately 0.03 diopters per year, compared to LASIK, which means in long-term data of 6 to 7 years, we observe regression rates up to -1 diopter. So it's somehow in between. What about aberrations or higher order aberrations? Well, you will find studies showing different data, but this was one of the first ones showing that a SMILE may induce less higher order aberrations than femtosecond LASIK. As I mentioned, there is also a study out showing exactly the opposite. So, as in many studies, you will also have two sides. But at least I think these two techniques are also comparable in terms of induction of higher order aberrations. So what about the optical zone centration? Because some surgeons are very worried about the centration because you're used to the eye tracker system in excimer laser ablation, and in SMILE it's just the focusing of the patient, so which maybe is not that accurate. But it turned out, it was published from Dan Reinstein, I think 2 years ago, or 3 years ago, in the Journal of Refractive Surgery. He compared 100 SMILE eyes and 100 LASIK eyes, and he does not find any difference in optical zone centration between SMILE and LASIK. So what about safety in terms of biomechanical? This is a hot topic. It's well discussed, and it's based on theoretical models. So in theory, in SMILE, we preserve the anterior part of the cornea, which means the anterior part is untouched, which gives you more stability after the treatment compared to LASIK. Because, as it's shown here, in the first slide in PRK, you see we have only the ablation. In LASIK, we have to calculate the flap and the ablation, and the residual stromal bed is of course less. And in SMILE, we keep the anterior residual stromal, means the cap thickness. My preferred cap thickness is approximately 130. And the interesting part is that in the anterior part, we also do preserve Bowman's layer. And Bowman's layer is a very, very strong layer, and I think it's worth to keep it. And we heard it already, it's also the starting point of a beginning keratoconus, so there is a connection, it makes sense to keep this layer. Again, this is a theoretical model of biomechanics. It's not proven that it's really better, but I really strongly believe in this idea. Same with the sensitivity. So since in SMILE we are doing the treatment in deeper layers, we keep the very dense nerve plexus in the anterior part, which means we have less damage of the nerve plexus, and so less dry eye symptoms. And that's what we really find in our patients coming to our office after treatment. It's in my hands, it's maybe the biggest difference the patient is feeling after these treatments compared to LASIK. So there's a very nice study published in Ophthalmology 4 years ago. A French group did some comparison study between SMILE and LASIK in terms of dry eye. And what we find here is a highly significant difference that SMILE patients do need significantly less tear substitute eye drops than compared to LASIK patients 6 months after the treatment. So what about complications? As in any other surgical procedure, we have to deal with complications. In SMILE, this is one of the first studies in SMILE, so you see a lot of complications, but most of them are minor complications. Of course, sometimes it's hard to remove the lenticule, so the extraction of the lenticule sometimes is difficult. especially if you have so-called black spots during the procedure. We have to deal with some kind of abrasion, but it's actually a very small complication, and sometimes also cap perforations, which is not that bad as it sounds. I want to show this short video where we had some cap perforation. I don't want to draw your attention to this laser procedure because it's cut with the video if something went wrong. Don't take attention on this. We are talking about the preparation. This was at the very beginning. We didn't have a proper instrumentation at that time, so we opened the incision, separate the layer, and now with the LASIK spatula we try to loosen the top of the cap, and now it happened. I'm not sure whether you could see it. So there was punched through the cap, which looks very terrible in the moment, but if you think about what you do during LASIK, where you open all this circle, it's actually a piece of cake. So nothing happens. Luckily, it was easy to remove the lenticule, but you still have to think about it's a new surgical procedure. It is really to do with corneal surgery. You have to do a lamellar dissection. So this was the worst case I had. So it was not, thanks God, not in our institute, but it was a referral from somewhere else. A surgeon who did not stop while he had difficulties removing the lenticule. He tried with all kinds of different instruments, and the patient ended up with a massive scarred cornea. And here you see the Scheinfeld image topography, and ended up in a DLK because it was too much scars and too much irregular astigmatism. This is definitely the worst case what could happen. So again, there is a learning curve in SMILE. If you're talking about pros and cons, it might be a con, which means you have to have some kind of experience. There are nice textbooks showing you a stepwise approach for successful SMILE. At the last point are the retreatments. Many people think, well, in SMILE, how could we retreat? There are many options. If you have many options, it means that maybe there's not one good option. So what we try to figure out is which one is the best option. So there is a publication of a subcap lenticle extraction, which means a secondary SMILE. This is not recommended by a company, and it's maybe not very easy to do. So there's just a case report, it's not a study. So, but it still is painless. What about thin flap LASIK? You know, the group of Dan Weinstein in London prefer a thin flap LASIK after SMILE, but you have to be very accurate. You have to have very accurate measurements as anterior segment OCTs, but it's you have a quick recovery and it's still painless. What about surface ablation? Surface ablation is pretty easy to do. It's safe, as we know. But of course there's no quick recovery and it's not painless at all. And there's another option, and this is the option recommended by the company of Zeiss. This is the so-called circle procedure, which means that you could convert the cap into a flap. That's the procedure which is recommended. I just want to show you the direct comparison of our two studies. First, this is the video of a circle procedure, which is first there's the vertical cut, then there's a lamellar ring-shaped cut, which converts the cap into a flap. You see the hinge on the right side, and now you just have to open and go on like a normal LASIK procedure. And I did it several times, and I have to say it's actually a pretty easy procedure, and it is easier as it looks. You see you have the optical treated zone over here, and you can go on like a normal LASIK procedure. So we published two different papers. The first was surface ablation after SMILE, and the second one was circle treatment after SMILE. The problem was it was difficult to compare each other because we had different MRSE, and we used only myopic ablations in surface ablation group, and in the circle group we also had hyperopic ablations. So what we did is we analyzed retrospectively 72 eyes treated with surface ablation and circular. We matched 24 eyes, so 12 eyes each group, perfectly with MRSE and age. So it was a multi-center study in Munich, Linz, and Cologne. We did the SMILE procedure as usual, the surface ablation with MMC, and the circle was a so-called pattern D. The time to retreatment was approximately 10 months, the MRSE approximately 1 diopter, and target was plain in all the eyes. So here are the results about the direct comparison, and in both groups, circle and surface ablation were absolutely comparable with very satisfying results. So we had just one loss of line in the surface ablation group, but 33 gained one line. And in the circle group, we had no loss of lines, but only 70% gained one line. Target refraction was also pretty accurate, although the circle group tended to be slightly overcorrected. Just want to show this slide. Of course, it's not a big surprise that there is, of course, one big advantage in the circle group, that the time for recovery, for visual recovery, is way faster in the circle group compared to the surface ablation group. So, to summarize the last point, the surface ablation and circle are both safe and effective retreatment methods after SMILE, so we can retreat residual refractive errors after SMILE. The refractive results seem to be comparable. It's kind of an individual approach of each surgeon. Some surgeons talk to their patient, they promise a flapless procedure, so they will rather go with surface ablation. Others say, I promise my patients a painless procedure, they rather go for a circle procedure. So as a major advantage, circle is painless, as I mentioned. So as a take-home message for SMILE, in my hands, one of the biggest advantages, SMILE induced less dry eye symptoms than after LASIK. The refractive outcome is comparable to femto LASIK. We face a very low complication rate, but we still do have a learning curve in this new procedure. We have theoretically a higher biomechanical stability. I think larger studies will show that, hopefully. We still don't, we are not able to treat hyperopia so far. We don't have any eye tracking system. We don't have wavefront guided profiles, and we don't have an eye tracker as we are used in the excimer laser treatments. I mentioned it, there is a learning curve. I know surgeons who stopped doing SMILE because they suffer with problems to extract the lenticule. And so far, I think that's also a big disadvantage. So far, there's only one company providing this new technique. There are 2 companies working on it, and I hope they will release it this year or maybe next year. So, SMILE is safe and effective treatment for myopia and astigmatism, and also in low presbyopia. We published a study for monovision in SMILE. SMILE enlarges our armamentarium for corneal refractive treatments, so it's not instead of LASIK, it's another treatment option. And I think, and that's why I like and prefer SMILE, the aftercare is super easy. You don't have any management of bandaged contact lenses, no flap-based complications, and no haze afterwards. And as I mentioned, further developments could bring significant advantages in the future. Thank you so much.
Much. We'll continue on the same topic, SMILE. I'd like to invite our next speaker, Dr. Mohammadi, who will speak on SMILE.
I'm sorry, this is the wrong slide. Actually, Dr. Kusaimer made my work quite easy. My lecture was already very much focused. I can probably browse my slides quite fast. Well, I'm not talking about the I have already thanked many times from Dr. Rashida Saidi, of course. My talk is not focused on related on the accuracy and optical quality, which are very hot topics in film to smile. And I do not generally compare it with surface ablation. Hyperopia at the moment is not applicable. And the focus is mostly on the safety. I will show some of the clinical scenarios which, based on safety, we can recommend probably femtosmile instead of femtosecond LASIK. US FDA has approved in 2016 myopia, mostly spherical myopia up to 8 diopters and essentially without no cylinder less than 4.5. Europe and Asia already, they're ready to embrace any other new procedures. Americans normally do not accept even the procedures that are being invented outside America quite much later. The case was true for cross-linkage as well. But anyway, the range that has been used in Europe and Asia is quite wider, up to 10 spherical myopia and also 6 diopters cylinders. Almost 1 million procedures have been performed until 2018, and as I mentioned, VisualMax was the only company. A recent trial just reported in 2019 a 3 months follow-up study in hyperopia. And now let's look at the comparative evidence. I'm going to quite browse quick. You see in the upper panel, femtosecond LASIK, and there is a more loss and more protracted hyposthesia is visible in case of femtosecond LASIK. In terms of the tear film, you see that it is more affected in microceratum and femtosecond LASIK breakup time of the tear film. And it also, there is an increase in the osmolality in the core. Dry eyes in general. But if we consider the ocular surface disease index as the gold standard for diagnosing and following the treatment of dry eye, again, there is a superiority for SMILE. And in terms of meniscus height, area, and depth, the height again shows the similar trend, and they have a better status for better profile for SMILE. As mentioned by Dr. My friend in the previous lecture, the biomechanics is probably the hottest topic related to SMILE and its comparison with PRK and LASIK. And the story of which one is superior never ends, seems to. Even if you consider some higher degree and higher amounts of refractive errors, phakic intraocular lenses also come into the confusion. In terms of corneal hysteresis, the data is not clear-cut, and they're very much comparable. But CRF, there is one study that shows the superiority of femtosecond SMILE. And here, again, you see the deformation by force by Corbus. It provides more convincing evidence in support of SMILE. You see that in the right graph, you see the recovery. Some recovery is visible in the SMILE group, but not in the femtosecond LASIK. This is already discussed, and that's it probably. In terms of the tissue efficiency, SMILE is a little bit inferior because for every one diopter, it removes almost 20 microns. But for an optical zone of 6.5, we almost remove 15 microns per diopter in PRK and femtosecond LASIK. But as it was mentioned, Bowman's layer as the strongest layer in the cornea is preserved, and also anterior stroma. And then if we consider the novel metric percent tissue altered, then probably we can come to the conclusion that SMILE might be even better than PRK, might be because of the preservation of Bowman's layer and anterior stroma, because it bypasses, in fact. Well, there are two cases. We normally recommend them phakic intraocular lenses, but if the patient does not accept phakic intraocular lenses, and some of the patients just do not like having an eye or a lens in their eyes. They prefer not to have a lens in their eyes. And in my country, there is, economically speaking, it's quite much more costly to choose phakic intraocular lenses. This is one case that I should say that we can think of, easily we can think of femtosmile instead of phakic intraocular lenses as it is compared to femtosecond LASIK. I do not feel easy performing PRK or femtosecond LASIK for such a case, but I can probably feel more comfortable recommending a femtosmile procedure. The second case is a 30-year secretary with 490 microns for the thinnest point. Well, based on my decision, I consider this tomography, this pentacam normal. And the patient is motivated, of course, very highly motivated for refractive surgery. We routinely recommend, in such cases, phakic intraocular lenses or PRK. But excluding PRK or considering that the patient is seeking a painless and rapid recovery postoperatively, then again, I performed, the two cases that I just presented, I performed femtosmile for them. They are real cases. And this is the summary of my presentation. I can refer to 5 different clinical scenarios in which we can probably recommend femtosmile, feeling comfortable. Lower range PI, phakic intraocular lenses candidates in the range of maximum ablation of 9 to 11, in which the patient does not like to have a phakic intraocular lens to patients in which we can recommend SMILE. The other category is those who do not have much ablation but have a basic pachymetry of low baseline pachymetry with normal cornea. And these are, as I mentioned, will be phakic intraocular lens and PRK candidates, but the patient who cannot again afford the cost of phakic intraocular lenses, and the patient who does not choose PRK, again, SMILE might be, even SMILE might be considered as a better option because of the preservation of anterior stroma that I just mentioned, biomechanically speaking. In a marginally compromised patient's ocular surface who have the compromised ocular surface, dry-eyed patients, again, and highly motivated candidates, again, I guess the femtosmile is recommendable as compared to femtosecond LASIK and even to surface ablation. And the other category is moderate spherical aberration of 4 to 8 diopters, because we know that in terms of tissue efficiency, when you come to lower ranges of refractive error, femtosecond LASIK is safer, and the SMILE removes more tissue. So in the mid-range of 4 to 8 diopters, in which the very technical aspects of the procedure are less risky, I mean, the complications that were referred to, intraoperative complications to SMILE. Again, I think this minimally invasive or keyhole keratomiosis flapless procedure is recommendable. And finally, those who are engaging in combat, war, or some sports like wrestling, in which there is a risk of flap dislocation, again, SMILE could be recommended. Thank you.
Thank you very much. We have a change in the program, so next paper will be on biomechanics in keratorefractive surgery. It will be given by Dr. Ali Riva Istanbul. Please.
Excuse me. أيوة.
Good evening, ladies and gentlemen. It's a great pleasure for me to attend in this conference, and I should appreciate the organizers for their kind invitation and hospitality. There is no financial interest to disclose. Why should a refractive surgeon care about corneal biomechanics? To detect subclinical keratoconus, to detect at-risk corneas, risky corneas, and nowadays and in the future, probably, modifications of keratorefractive surgery. Now we know that there is a new concept for ectasia pathophysiology as proposed by Roberts and Dobbs, that a focal abnormality in corneal biomechanical properties precipitates a cycle of decompensation leading to a secondary localized thinning and then steepening. And so we are now knowing that probably keratoconus and at-risk corneas may start from the biomechanical defect. And how are biomechanics measured? We should remember that the biomechanics is response to applied force, and it can be destructive or non-destructive, and we prefer to have the non-destructive techniques to measuring the biomechanics. And how is response quantified with biomechanical properties? And these are some examples for biomechanical properties of related to cornea: elasticity, viscosity, and viscoelasticity. What is the elasticity? Elasticity is the capability of a strained body to recover its size and shape after deformation. And it's not time dependent, as a string that it's not dependent on how long or how fast you put the force. Its recovery is the same in all sessions. And what is the viscosity? It's the resistance of material to flow or permanent deformation. It is versus the elasticity completely time dependent component. And viscoelasticity is the presence of both elasticity and viscosity in the material, and also it is time dependent as viscosity. And there are some models of elasticity. You could see the elasticity is the measurement of the strain versus stress. And there are two types of modulus: Young modulus and tangent modulus in this topic. Young modulus is referred when a material is completely elastic. And in this case, it is completely linear. But in case of a material that is viscose or viscoelastic, this is not completely linear, and the modulus changes to tangent modulus, and there is a curve in the nomogram of the stress to strain. There is another factor that make complication, make the complex measurement of the corneal biomechanics, and that is the IOP. As the Laplace law says, the higher IOP, higher wall stress. And when we have the higher IOP, there is the steeper cornea, and it may change the corneal biomechanics. And how do we know about the cornea? It is viscoelastic. It is non-linearly elastic or hyperplastic. And there is different tests for loading and unloading the cornea. And as the IOP increases, the cornea exhibits stiffer behavior, and it may change the behavior of the corneal biomechanics. What about the devices to measure the corneal biomechanics? There are two commercial devices. Both rely on analyzing corneal biomechanics response to an air puff. One from the Racher company, Oculus Response Analyzer. You know that it's a puff customized to each patient. The main difference between Corvis ST and ORA is the air puff that is constant in Corvis and that is customized in the ORA. And this is the ORA nomogram. As you see, there is the air puff that make two peaks at the corneal applanation side, peak 1 and peak 2, and the hysteresis factor that is P1 minus P2. And the measurements produced by ORA are these parameters. IOP Goldman. Goldman correlated IOP is the average of P1 and P2. IOP corneal compensated IOP is empirically determined linear combination of P2 and P1. And CH, corneal hysteresis, is a viscoelastic response, is P1 minus P2. And CRF, or corneal resistance factor, is a viscoelastic response of the cornea, as it is empirically determined linear combination of P1 and P2. And what should we know about the aura? Many studies have also shown that both CH and CRF decreased in keratoconic eyes. We know that. And larger differences in CRF than the CH. There isn't any determinate cutoff, but as average CH in normal 10.8 versus 7.5 in keratoconic eyes, and CRF so that 11 millimeter mercury versus 6.2. And in summary, CH and CRF can be used for an accurate detection of moderate or severe keratoconus eyes, but their diagnostic ability is limited for incipient and keratoconus suspected cases. So we have challenges in this biomechanics by the aura. What about the corneal hysteresis? It is not indicative of stiffness, it's more important, or softness, because it is indicative of the corneal ability to dissipate energy. You could see the soft eyes can have low hysteresis, for example, in keratoconus, or stiff eyes can have low hysteresis, for example, in old eyes or in eyes with high IOP. There are some progressions in waveform analysis in the aura, but they are all limited accuracy in subclinical keratoconus as well. What about the Oculus Coris ST? It's an ultra-high spectral flood camera which used constant metered oscillated air path, and currently FDA approved only for tonometry and pachymetry. And there is so many parameters of Corbis, you know. The first set of parameters had relatively low accuracy. Best diagnostic accuracy may be related to deformation amplitude with the cutoff of 1.18 millimeters. It has the sensitivity as a specificity as you could see in the picture. For doing it better, for measurement of the corneal parameters that Corbis said to us, there is a corneal biomechanical index that introduced by the Ambrosio and Vincigura, that is a normalized index from 0 to 1 based on longitudinal analysis. And it includes several dynamic corneal response parameters, deformation amplitude ratio at 1 and 2 millimeters, applanation 1 velocity, standard deviation of deformation amplitude at highest concavity and a novel stiffness parameters. These are dynamic corneal responses that they add to Ambrosio's relational thickness to the horizontal plane. At the sum, they produce the CBI, or corneal biomechanical index. There is the main paper that they introduced this index, and there is a cutoff of 0.5 that, if used, TBI. It is the tomographic biomechanical index. The TBI is combined parameter based on sham plug-based corneal tomography and biomechanical assessment. And we know the bad display of the Berlin Ambrosio enhanced ectasia display, and there is a total deviation D that show the keratoconic eyes. When this parameters, that D, this parameter add to the CDI, they make the TDI that this is the printout of the TDI, and there is the cutoff of two cutoffs, 0.229 and 0.279 for detection of the keratoconus. First cutoff 0.79 for it could detect all keratoconus cases, and the second 0.29 could detect the normal cases from the full frost keratoconus cases. And you could see that the TDI is the best accuracy than the bad DI or CDI indexes. And there are nice manuscripts in the papers that show that the results of the TDI is accurate, and it is sensitive for detecting subclinical for frost ectasia among eyes with normal topography in very symmetric patients. But the main concern here is these trials are due in the cases of very asymmetric ectasia and normal topographic cases, not the completely normal cases. And if this TDI index could discriminate between the normal cases, completely normal cases from the bone frost keratoconus is unknown yet. There are so many papers that show that the accuracy of the TDI is very good. Is biomechanical evaluation necessary for every patient? There is a nice paper that shows that biomechanical analysis show abnormalities, various tomography and topography and tomography were normal completely. And based on these findings, the authors suggest the use of biomechanics as an additional diagnostic tool in every patient. And as a take-home message, an initial periclinical phase of an ectotic disorder could be theoretically first detected by biomechanical measurement. Comparing the normal and keratoconic groups, all indices versus bad or CDI or TDI, all indices demonstrated a highly discriminative ability. But comparing normal and very asymmetric normal topographic cases, TBI is more accurate than CBI or the bad D. And comparing normal and very asymmetric ectasia from the normal topography and tomography cases, TBI is more accurate than is the most accurate parameter of the measurements. And in addition to safety, such an evaluation may also allow for the customization of the treatments in the future. And also there is new methods of in vivo biomechanical assessments such as Brillouin biomicroscopy and swept OCT that could help us to know more about the biomechanics. Thank you.
Thank you very much. Last but not least, our next speaker is Dr. Hashami, who will give two papers. The first one on intracorneal rings, and the second one on presbyopia correction using the supercon.
Thank you very much. Good afternoon, dear colleagues. First, talk about the treatment plan and nomogram. Fortunately, this morning, Professor Sinjab talked about the role of intracorneal ring segment in the management of keratoconus. So I will focus on the treatment plan and nomogram. As we know, the one of refractive management in keratoconus is the intracorneal ring segment implantation, and today's femto-assisted intracorneal ring segment implantation. Yes. The objective of this procedure is to regularize the corneal surface and so reduce the aberration, improve contact lens tolerance, and allow spectacle correction, and stabilize or delay the ectasia progression and reduction of refractive error. The mechanism of the intracorneal ring segment effect on the cornea is to flatten the center of the cornea, and by the shortening the pass lengths of the collagen lamella on the center of the segment, so redistribute the corneal stress, interrupting the biomechanical cycle of keratoconus disease progression. Today, there are different types of intracorneal ring segments, such as Byzantine, Keraring, Ferraring, Myoring, Intacs, and Intacs scale. I will be focused on Intacs scale. I have any financial interest in this type. The Intacs scale with 6 mm optical zone, elliptical shape, 30 degree angulation, and variant the arc lengths, and the thickness vary from 210 microns to 450 microns. And we know about the mechanism of effect. The greater thickness, the greater effect and correction, and the smaller diameter result in more correction. And also, there is a different type and lengths of curling and also furring. The indications: keratoconus and any ectatic condition, occlusive marginal degeneration, iatrogenic, post-LASIK, and after trauma. The inclusion criteria for the intracorneal ring segment implantation is a progressive deterioration in the vision, 20 years age or older, clear central cornea, and the thickness in the incision site larger than 450 micron, greater than 450 micron. And the mean keratometer reading less than 58 diopter. The mesopic pupil size is important, and less than 6.5 millimeter, and contact lens intolerance. And the contraindication: acute keratoconus, high drops, low endothelial cell density, atopic, severe atopia, high expectation of the patient, and decentered PKP, and recurrent corneal erosion, and the thickness in the incision site, as mentioned by Professor Sinjab today, is less than 450 micron in the incision site. And any autoimmune or collagen vascular disease in pregnant and nursing period, and in patient taking some drugs such as Accutane. The surgical planning. The data required for surgical planning, first, manifest diffraction is very important, and the best corrected visual acuity. And topography and tomography. In topography, sagittal view and tangential map is important, and in tomography, the pattern of the ectasia, anterior and posterior elevation, and pachymetric map, and also coma pattern and coma axis. Mesopic pupil size is important because the diameter of the ring is important in the clinical outcome. And also we should determine the steep meridian, and according to the amount of corneal asymmetricity, and also select the appropriate nomogram as prepared by the company, additional technology or coloring and select the 5 mm optical zone or 6 mm optical zone according to this data. Intracorneal segment selection, one segment versus two segment, symmetric versus asymmetric, and the lengths. The choice of intracorneal segment and whether done symmetrically or with different size segment is based on mean refractive error, plano, myopic, or hyperopic, amount of astigmatism, location of the cone, a specificity value, and coma axis. All of these factors can be effective in the treatment plan in each cases, because in each cases we have to customize, and the outcome dependent on considering these factors. And mean keratometry lower than 45 diopter, and mean keratometry larger than 45. The incision site, temporal incision, usually for the inferior cone, superior incision for the central cone, and the depth of incision, usually in femto-assisted tunnel creation, 75%. And the incision site can be verified according to the topographic axis and positive refractive axis, and also coma axis. In PMD cases, the steep axis will typically present across the top of crab claw or kissing the topographic image. Symmetric versus asymmetric. In patients if myopia larger than astigmatism with central cone symmetric, if intact SK use symmetric SK segment. If myopia equal to astigmatism with central cone symmetric SK. If astigmatism larger than myopia or astigmatism with hyperopia with decentered cone, and the decentered cone apex in the 3 mm to 5 mm topographic zone, one segment intact SK with the 6 mm optical zone is recommended. If myopia and astigmatism is equal, with the decentered cone, asymmetric segment is recommended. If astigmatism larger than myopia with central cone, a paired segment of 90-degree length or 130-degree length in the more peripheral 7 mm optical zone. If astigmatism larger than myopia or astigmatism with hyperopia with decentered cone, and the cone apex placed in the 3 to 5 mm zone, the one segment intact escape with the 6 mm optical zone. And if astigmatism larger than myopia or with hyperopia with decentered cone, and the cone apex in the 5 to 7 millimeter, it's preferred to do in the one segment intact escape in 7 millimeter optical zone. As mentioned in the previous slide, if myopia larger than astigmatism, paired with the central cone, paired symmetric escape. But in my experience, two segments with the 450 micron thickness and 150 degree length induces hyperopic shift about 3 to 5 diopter. So in myopic cases, if the myopia more than 3 to 4 diopter, I prefer to implant two pair segment, symmetric segment with central cone with thickness of 450 micron and with 150 degree length. If myopia and astigmatism is equal, if a myopia and astigmatism is equal, with this decentered cone asymmetric, paired asymmetric escape, and if astigmatism larger than myopia or with hyperopic case, 90 degree or 130 degree length paired symmetric escape. And in this case, as you can see, eccentric cone with the refraction -3 in 130 degree. So one segment intact escape with 6 millimeter optical zone is recommended in these cases. And if you use Caroline, you can, according to the software and recommendation of the company, you can plan your cases. But I think in each cases, we have to customize the result according to pneumogram. And the other factors that may affect the amount of sphericity, chroma, and mean K. And according to this algorithm, in patient with low sphericity and low chroma, that means regular astigmatism, regular keratochronic patients. So in these cases, pair segment, we choose pair segment according to this cone's position. And if high sphericity with low chroma, so in this case, if astigmatism low and myopia larger than astigmatism, pair segment, and if high astigmatism, two segment with lower lengths, 130 degree. And in some cases with highly irregular keratoconus, low sphericity and high chroma pattern. In these cases, according to the mean K, you can implant one segment or two asymmetric segments. And the highly irregular keratochronic patient, high sphericity and high chroma light. So if low astigmatism, paired segment of 150 degree arc according and the thickness according to mean K, and if high astigmatism, shorter short length size, 130 degree. And the other factor that predicts the outcomes is the according to a study by Professor Alio, was in the cases that pre-operative best corrected visual acuity better than 0.2 and lower than 0.6. So a predictive factor for this procedure is the pre-operative best corrected visual acuity, spectacle corrected visual acuity. If the patient between 0.2 to 0.6, the outcomes very predictable, and the satisfaction in these cases is very high. And this research showed that corrected distance visual acuity decreases statistically significantly in patients with mild keratoconus, but statistically significant intracorneal segment 1 month, 2 months after that by cross-linking, because in this study shows that all progress after 3 years. We also studied the implantation of 1 segment versus 2 segment intact scale in the all grade of keratoconus, and this study showed intact case 1 segment or 2 segment by using the femtosecond laser to create channel is safe and effective, and very effective in early type of keratoconus. If implant 2 segments of intact escape with the thickness of 450 micron and 150 degree lengths, about 3 to 5 diopter hypertrophic shift maybe occur after the implantation of this type of rings. So the other factors that should be considered and maybe help to predict the outcomes in the thinnest point of the ectasia and the distances from the center of the pupil. If the distance is less than 1 millimeter central cone, and if the thinnest point 1 to 2 millimeter distances from the center of pupil paracentral, and if more than 2 millimeter is precentral. And the other factor is the differences between the topographic axis and coma axis. If the distances and the degree of this angle lower, the more regularized keratoconic patients. You can see the location of the coma, the thinnest point, the distances from the center, the axis, topographic axis, and the coma axis. All may be effective in the prediction of the clinical outcome of the ring implantation. According to a complete evaluation and a refraction, topographic, and aberrometry, we can determine the treatment plan and choose the type of intracorneal ring segment for each patient. If the time, I would like to share some cases if I have time. If no, I'm going to the next slide, please. Okay. Thank you very much. I would like to. As you know, the presbyopia is a challenging and we have different options for the management of presbyopia. One of these technique is the LASIK and suprachoroidal, the software that produced by Bosch in the Technolas 270 and now in 10.0 excimer laser. There is in presbyLASIK there are different type of ablation profile for the correction of the presbyopia, such as central hyperopic add, decentered hyperopic add, central chroma, combined myopia and hyperopia, and super aspheric ablation profile. Suprachoroidal was developed in late 2009 and is suitable for the treatment of hyperopic and myopic cases, and also in post-LASIK eye, and providing near addition while minimizing undesirable aberration, and utilize aspheric ablation profile in hyperopia or myopia, and also use corneal keratometry and Q value to optimize the ablation profile, and use a full XY and rotational eye tracker. The ablation profile, after the correction of the distance myopia or hyperopia, for the presbyopic correction on the 3 millimeter central 3 millimeter zone, about 1.5 to 2 diopter steepening occur after the suprachoroidal ablation profile in hyperopic or myopic cases. So the topographic change after suprachoroidal ablation profile is the steepening of the central of the cornea about 2 diopter, and the transitional to in the 3 millimeter center of the cornea. The purpose of our study is to assess the visual and refractive outcome and complication of unilateral suprachoroidal multifocal corneal femtolase in non-dominant eye for the correction of hyperopia and presbyopia. In this study, enrolled 54 eyes who had bilateral femtolase for the correction of hyperopia plus suprachoroidal in non-dominant eye. Monocular and binocular uncorrected, distance corrected visual acuity, uncorrected near visual acuity, and distance corrected near visual acuity at 40 centimeter, central corneal power, and high order aberration changes and complications were evaluated over 6 months. Inclusion criteria was up to 3 diopter of hyperopia, up to 2 diopter of astigmatism, mean keratometry between 41 to 45 diopter, angle kappa less than 8 degree, patient's age over 47 years, and that needs at the 1 plus 1.75 diopter with the maximal differences with 0.75 diopter between cycloplegic and manifest refraction, and the pupil between 3 to 6 millimeter with the central corneal thickness larger than 500 micron. The exclusion criteria presence of ocular surface disease, clinically significant corneal opacity, abnormal corneal topography, any sign of binocular vision anomaly at distance or near, and limitation for LASIK surgery. The mean age 51, and the in dominant eye, the mean refractive error plus 1.4, and in non-dominant eye or supracore eye, plus 1.54 diopter of hyperopia. Result: the mean post-operative spherical equivalent refraction was minus 0.03 diopter for the dominant eye and minus 0.8 for the non-dominant eye, because we attempt for the micromolar vision in non-dominant eye, and the target refraction was 0.5, minus 0.5. The mean binocular uncorrected distance visuality was 20/25, and the mean binocular uncorrected near visuality was equal or larger than J2. At 6 months, all patients achieved 20/25 and could read J2 binocular. Mean non-dominant eye uncorrected distance visual acuity was equal or larger than 20/50 at 6 months. The mean central keratometry stiffening was 2.5 diopter, and there were significantly more negative spherical aberration and vertical chroma in the central 6 mm in supracore eyes. 98% of these patients didn't need any glasses for distance and near vision. The 6 months after operation, the uncorrected distance visuality over 80% larger than over than 25/50, and in best corrected visuality, all cases are over 20/40, and in dominant eye, all patients, the uncorrected visuality better than 20/25, and the corrected distance visuality also better than 20/25. And the uncorrected near visuality in supracore, all cases equal or better than J2, and corrected distance, many near visuality, 80% of cases better than J3. And the amount of high order aberration, the chroma increased significantly, and also spherical aberration increased significantly in supracore eyes. But in dominant eye, the chroma not changed significantly, just spherical aberration increased significantly. The cylinder and the mean spherical equivalent was stable during the study, but the mean spherical equivalent in non-dominant eye was minus 0.8 diopter. So, according to this study and other studies, supracore is a corneal approach to treat hyperopic presbyopia and induce micromolar vision with this ablation profile. And in our study, all patients had the binocular uncorrected distance visuality 20/25 or better for distance at 6 months post-operatively. For near vision, 60% of patients had uncorrected near visuality of J1 or better, and for near vision at 6 months, and all patients had an uncorrected near visuality of J2 or better. We have better results with the same algorithm, probably because we included micromolar vision to improve the compromise between the distance and near vision. As with the many other presbyopia correction procedures, the inclusion of near vision involves a compromise which needs to be discussed and explained to the patients. So, supracore procedure in non-dominant eye may improve functional near, intermediate, and distance vision without significant photic phenomena in presbyopia patients with low and
very much. I think we are far behind the schedule, so we have no time for discussion. I would thank all the speakers for the very interesting contribution to this symposium. And I suggest if you have any question to approach the speaker during the gala dinner, which is taking place, I think, on site. And thank you very much.